Good morning. My name is Andrew Thomas. I'm Chief Clinical Officer for the OSU Wexner Medical Center. I want to take a moment to welcome our guests from the media here today. We have been bringing these media briefings out to the community periodically during the course of the COVID pandemic to make sure that we're sharing the best and most updated information that we have around the science around the pandemic and around our community's response to the pandemic. I'm joined this morning by Nora Colburn, who's one of our infectious disease specialists here at the Wexner Medical Center, and also as Medical Director for Clinical Epidemiology for the Ross Heart Hospital, and by Dr. Michael Kakovic, who is a maternal fetal medicine specialist, so for a high-risk OB doctor, and who also specializes in the impact of heart disease on women who are pregnant. So we'll be talking with them a little bit more about their perspective today on pregnancy, and women of childbearing age as it relates to COVID for the infection as well as for the vaccine. I will take a couple minutes before we get into the topic of COVID and pregnancy to share some data. You should be seeing a graph of our data for COVID in Zone 2. Zone 2, as most of you probably remember, is over 40 hospitals and health systems, is about a third of the state. So it represents 37 counties here in Central Ohio, stretching down in South Central Ohio as well as Southeastern Ohio. So that group gets together on now a daily basis as of this week to talk about our hospital capacity. The blue line on this chart represents the census on each day of active COVID patients in the hospitals in Zone 2. The red line are patients in the ICU, and the green line are patients on the ventilator. As you can see, back in December, our highest day for the COVID census in the zone was just over 1,200 patients in the hospital on our worst day. If you think just 10 days ago, on August 29th, we were at 600 patients in the hospital in the zone. On Wednesday, September 1st, we moved to 700 patients. On Monday, September 6th, just a few days later, to 800 patients. And yesterday, we topped 900 active patients with COVID in the hospital in our zone. When you think about our worst day being at 1,200, and we're now to the point where over 60% of the state's adults are vaccinated, we're seeing unprecedented numbers of COVID patients in the hospital, given such a large percentage of the population is vaccinated and protected against those most serious complications of the infection. Of note, I will say it's important to note that back on August 1st, we were at 150 patients. So this is a six-fold increase just in the last 5 or 6 weeks. Then the trajectory, as you can see, of that blue line is quite steep. What we've known from previous surges in the pandemic is that as case numbers in the state go up, hospitalizations tend to trend up. And until we see those case numbers peak and come down, we can expect to see continued rise in the number of patients in the hospital with COVID for about 10 days to 2 weeks after that period of peak and the case numbers coming down. As you look at case numbers coming out of Labor Day with K through 12 schools starting, we're averaging now a 7-day moving average in the state of over 6,000 cases per day. And there's really at this point no sign of that breaking, plateauing, and coming back down. So there are significant concerns across the hospitals in the zone about capacity. Multiple hospitals have made decisions to limit their routine operations, limit normal services that they provide, as well as a number of hospitals that are boarding patients in their emergency departments because there just aren't any inpatient beds left in their facility. We're working together to partner to move equipment, to move medications, and obviously move patients when needed between the hospitals in the zone. There's great partnership, but I think we're now, as most of you know, we've been saying this now for a number of weeks as we've seen these trajectories coming. There's significant concern about where we go. Region 7 and Region 8 are the two more rural regions of Zone 2, and I do briefly want to show their data. This is Region 7, which is the area directly south of Columbus down into the Portsmouth and kind of over to Gallipolis. They are actually at almost their total for their worst day back in December in terms of the COVID census. In Region 8, which is more out Cambridge, Zanesville, all the way up to Steubenville and kind of down to Marietta, Region 8 is approaching near their peak from back in December. So this is something that's not just affecting Columbus. This is affecting both the rural, the suburban, and the metropolitan areas of Zone 2. and really putting pressure on hospital systems across the entire part of the state. So I'll stop sharing my screen there for a second, and I want to turn to my colleagues here from Ohio State. We want to spend the rest of our time this morning talking about COVID and pregnancy. Before we get into that, Dr. Colburn, would you give us a quick update of where we are with the Delta variant, what we've learned about the Delta variant over the past couple of months, and really how that's changing our approach?
Absolutely. Thank you. So the Delta variant has quickly become dominant across the United States. It is essentially 100% of the virus that we are seeing right now. The Delta variant is much more contagious than the Alpha variant and even the original strain. And so we can spread it much easier amongst people. This is why masking is so incredibly important. The other most important tool we have is vaccination that can prevent the spread of this Delta variant.
So vaccination is still an effective tool.
100%. I would say that is the best tool in our toolbox to prevent infection and, most importantly, to keep people out of the hospital and prevent death.
Can you discuss briefly breakthrough cases and what that term means?
Right. So when we say breakthrough case, that means a person who has been fully vaccinated who gets COVID. What we are seeing, though, in these breakthrough cases, that they tend to be much more mild cases. So very, maybe the upper respiratory symptoms such as runny nose, sore throat, maybe some fatigue. The vast majority of people who are in the hospital right now are not fully vaccinated. So the Ohio Department of Health actually has an excellent dashboard. It's approximately 98 to 99% of people who have been in the hospital since January are not fully vaccinated.
Thank you, Nora. Dr. Kakovic, we'll turn to you to talk a little bit about pregnancy. I know we've certainly seen pregnant women come in with COVID. What are you seeing now as we move to the Delta variant, as Dr. Colburn's described, that's more contagious in terms of the impact we're seeing with pregnant women, either vaccinated or unvaccinated?
Biggest thing we're seeing right now is sicker women. This is as many surges as we've had in the last year and a half. Right now, we've had more patients critically ill on ventilators and ECMO than we've seen the entire time since the pandemic started. This is very frustrating because we have a tool against it, and the best tool against it is the vaccine. Every patient that we've had that's been critically ill has been unvaccinated. The vaccination rate amongst pregnant women in the country is about 22% average, running from 10 to 40%. And this is certainly a problem because the best thing that any mom can do for their baby is actually get vaccinated.
So we've used vaccines in pregnant women for generations, haven't we? This isn't a new concept for pregnant women to make sure they're vaccinated, correct?
Correct. And the thing is, to me, there's nothing more natural that you can do than give mom an injection that allows her to give the baby antibody. And that's been the basis of vaccinations throughout pregnancy. The only ones that we've never really used in pregnancy are live vaccines. And the mRNA vaccine that we're seeing with COVID does not follow that pattern.
Correct. So when you talk to your patients or you talk to your friends or family and have concerns, what are you hearing from pregnant women about reasons why they might not be getting vaccinated? Any misinformation or things kind of out of context that you'd like to set straight today?
Well, anytime you give any pregnant woman any medication, the first thing they ask naturally is this going to hurt my baby? So that's the first thing we want to get out there. And my answer to that question is that, number one, what's the most common cause of fetal death? And, not to sound dramatic or anything, but it's maternal death. So if we don't keep our moms healthy, then we're not doing anything for the fetus. And that's the basis of this vaccine, because what we're seeing is critically ill moms and with a preterm birth rate of approximately 50% across the country. And that's unconscionable that this is happening. But these women are coming in, they can't breathe. Obviously, the baby's not getting oxygen, and they're getting delivered early. Now we have a baby in the NICU that's been delivered through a disease process, and it just opens up a whole new problem.
Right. In terms of women of childbearing age that might be thinking about getting pregnant, I know there's been a lot of kind of misinformation out there about the impact of the COVID vaccine around the ability to get pregnant, around fertility. What do you talk to your patients about?
Well, I wish I knew where that came from. I understand there's some misinformation on the internet. The bottom line is there's no vaccine that's ever been shown to create infertility in either men or women. And the analogy that I use with patients is, don't you think the pharmaceutical companies would use that method if they knew that they could have a vaccine that could cause infertility as a contraceptive? Would be a big money maker. But basically, I try to dispel that notion right away that this is not something that has ever existed, and certainly doesn't exist in this vaccine. And we've had this vaccine, at least in the lab, and we've been familiar with it since the 90s.
The mRNA
vaccine, excuse me.
Yeah, exactly. Dr. Colburn, you're a relatively new mother. I know you talk to your patients about this. What would you like to share with our community, just from your perspective as a mom, about the issue with vaccination?
Yeah, so I've lived through this pandemic on a variety of levels. So I'm an infectious disease doctor, so I've been rounding on patients with COVID since the beginning of the pandemic. I'm also one of our hospital epidemiologists, so I've also been in many of the meetings trying to plan strategies to protect our patients and staff from COVID-19 and rolling out our vaccine. And I was pregnant during the pandemic. And so pregnancy is hard. It's a very emotional experience. And then I think now when you have a global pandemic, that it can be really nerve-wracking. And every pregnant mom wants to do what's best for their baby. Made sure that I had all my vaccines because I wanted to make sure that I was able to pass those protective antibodies on to my baby. So little babies have a very immature immune system, and they really rely on mom's antibodies to protect them. I also have been very strict about mask wearing, and anybody who's around my baby has, wearing a mask, and making sure that anybody who comes into contact with my baby is vaccinated. And when my little guy is old enough, he will be vaccinated. These rumors, I talked to a lot of young women about the fertility. The fear of fertility is real. And I understand that 1 in 8 women has issues with fertility, but there is absolutely no evidence to support that vaccination of any kind can cause infertility. In fact, there's actually been studies looking at this. There was a study of women in an in vitro fertilization clinic, and there was absolutely no difference in pregnancy success rates, whether you were vaccinated, unvaccinated, or had a history of COVID. There's even an article in JAMA looking at sperm counts in men. So this is a cruel rumor on the internet. We have studies to back this up. And I would urge every woman, whether she's a mom now or wants to be a mom, to get vaccinated. It is the 100% the best thing that you can do for yourself and your baby. To risk a fetus life and your little baby's life, it breaks my heart. And it's been really hard and heart-wrenching to round on these pregnant moms and watching their babies be delivered early and go to the NICU. It's terrible, and it's preventable.
Thank you so much for sharing that, Nora. I think it's such a great personal message that has a lot of professional and science background behind it, but I really appreciate you sharing that. At this point, we want to transition into Q&A. Once again, for those members of the media who are here with us this morning, if you have a question, please enter it in the chat and I'll recognize you or raise your hand. If anyone is only on the phone and not on their computer, if you have a question, please feel free, once we have a pause, to unmute yourself and ask the question. Our first question this morning is from Candace Price from WHIO.
Hi, good morning, everyone, and thank you so much for coming together to give us this important information this morning. So my question is about the MU or MU variant, however that is said, I'm not sure yet. What do we currently know about it? And we heard from Dr. Anthony Fauci that really it's too early to say how infectious it will be, but do we know anything more about it at this time, and whether it's more dangerous than Delta variant?
I'm going to turn to Dr. Colburn to take a crack at that question.
I'd be happy to. So the Mu variant is a variant of interest that was designated by the World Health Organization last week. So the World Health Organization, along with many other federal and national health agencies, are scanning and looking for the variants. Variants are going to happen. This is a natural phenomenon of viruses. So they're being monitored very closely by scientists. It was first detected in Colombia in January of 2021, and it's currently identified in greater than 39 countries. Right now, there is maybe some laboratory data that they're looking at, but prelim message is very unclear and needs to be studied more specifically in people. I think the important thing to remember is right now, the Delta variant is here and now. It is over 99% of the variants in the United States. This is what putting all of our patients in the hospital and is what can be prevented with vaccination. So the scientists will continue to monitor these variant of interest and update accordingly.
Thank you, Nora. I think we've all unfortunately gotten used to new letters in the Greek alphabet here over the past few months. But I think that certainly, can you talk just briefly about variants and what we can expect in the future, that really this trajectory of having additional variants is not too surprising for a virus like this?
Actually, all viruses. So whenever a virus replicates, actually when any organism replicates and replicates their DNA, there is a, what do I say, like a fact checker, or they're checking how accurate it was. Now humans, when we are making new cells, ours is very accurate, so we rarely will make a mistake. Viruses, that checker is not very accurate, so you often will see these mutations happening a lot over and over again. Some of them are significant and some are not. So I also take care of a lot of people with HIV, so we see this quite a bit in HIV. Many of these mutations are not significant, some are, and this is why we need to watch them both in the laboratory and do testing, but also in the clinical setting of what does it really mean in terms of clinical disease and vaccines. And I think for the Mu variant, it's too early to tell right now. And so I think the best thing we can do is double down on our vaccination, our masking, and get this current surge of Delta down as quickly as possible.
Thank you. Next up, question, Max Philby from the Columbus Dispatch.
Yeah, thank you all for doing this today. Obviously, a week from tomorrow, it sounds like we might get a decision or at least a recommendation on COVID booster shots. And just kind of wondered in general what you all expect that rollout to look like and what the planning for that has been so far.
Sure. Just briefly, I can cover that, and then I'm going to ask Dr. Colburn to add in as well. We've been doing now for, I believe, 3 weeks, third doses for immune compromised patients. The CDC and FDA came out, and the state of Ohio has endorsed for those 2 to 4% of patients in the state of Ohio that are either under active cancer treatment, they're an organ transplant patient, or they're on a medication that impacts the ability of their immune system to fight the virus. Some pretty clear criteria of those folks benefit from a third dose. That's very different than what I think your question's about, Max. What you're talking about is the average patient who's not in that rare category of 2 to 4% of patients, and the benefit of them having a booster or an additional dose of the vaccine. Certainly the ACIP, which is the committee within CDC that determines vaccine policy and vaccine guidelines, has been discussing this over their last 2 meetings. We are all, I think, waiting for the final recommendations from the federal government. While the White House has certainly come out with some projections forward on how this might look, I think there's still some science yet to be done. Our expectation is that at this next meeting, there will be more direction. Internally, what we're doing is going back and planning, obviously the first month or so of vaccine rollout here at the medical centers for our own healthcare providers. Then moving into that mid-January timeframe into the elderly public, and then moving through folks that would mainly by age criteria or by disease criteria. So we have a good sense of what those numbers look like and when that trajectory may really hit. There's some thinking that it may be at an 8-month window from the end of your second dose for the mRNA vaccines that people would be able to receive a third dose. So we are making some preparations, but until the final guidelines are out, whether there's going to be an age cutoff for that or other distinctions that the CDC and FDA may put in place, we're not obviously announcing anything, but we are making preparations to, much like all the retail pharmacies are, much like the health departments are, much like a lot of provider practices are, we're making some preparations to be able to increase our capacity to do third doses for those patients that desire them. Dr. Colburn, any other information that you have? I know you pay pretty close attention to that as well.
Yeah, so everybody is waiting for ACIP to review the data, and that's the most important thing, is a careful review of the data to determine what makes the most sense clinically for people. The other thing I would add is that it's really important for when we roll out vaccines that we get as much of the population vaccinated as much as possible, because if you decrease the amount of susceptible people, that virus can't transmit as easily. So even if we do have some waning immunity over time, if we have more of the population vaccinated, we're going to have a much greater benefit from that. So that's also, so yes, we need to plan for third doses, but we also really need to push first and second doses tremendously, and people have not been vaccinated yet.
It's not an either or situation. It's got to be a both and. We need those people to get their first and second doses as much as people to get their third.
Yes.
Next question, Lindsay Mills from Channel 10.
Hi, yes, good morning. Thanks for taking my question. Circling back to pregnancy and COVID diagnoses and the babies that are, being born early, prematurely. Do we know how common it is at this point? Like, is there a number? Is there a statistic to say an expecting woman with COVID is, X more likely to deliver early?
Mike, you want to take that one?
Sure. Well, basically, right now, the data that we have, not here, but nationally, is about 48%. So you have to understand the challenge. And we're looking at babies 26, 27, 28 weeks. Women come in, they can't breathe. The best monitoring that we have to see if the fetus is doing okay is the heart rate. At some point in time, if the mom isn't oxygenating the fetus, the heart rate is going to go down. And we're kind of at a quandary at that point in time because you don't know how sick the mom's going to get. So ultimately, that is resulting in preterm birth, which is what we call iatrogenic preterm birth. It's not the virus that's actually causing it. It's the fact that mom is so sick that she can't house the fetus very well anymore. So as I said, it's about 48% across the country in these very, very sick moms.
Mike, can you briefly talk about the difference between delivering at 36, 38, 40 weeks versus say 28, 30 weeks? What happens to a baby that's born at 28 or 30 weeks that wouldn't happen if maybe they made full term?
So ultimately, the challenges of taking care of those babies is that the first thing is that are their lungs developed? And ultimately, sometimes if you can't predict that a baby's going to be born, you can't give the mom medications that's going to help the lungs being born. Obviously, in things like preeclampsia, preterm labor, sometimes we can hold it off. But if a mom comes in critically sick and her baby's not doing well, we don't have that kind of time. The second thing that happens ultimately is bleeds in the head. And bleeds in the head are as bad as they actually sound. They're brain bleeds, and they cause essentially the worst case scenario, cerebral palsy. Certainly best case scenario is sometimes just some minor neurological deficits. But these are things that are totally preventable. I mean, there's so many things in obstetrics that we have no control over. But honestly, this is something that I feel that we have control over if we have moms that are getting the vaccine. And as Dr. Colburn said, this is the best thing a mom can do for her family, a mom can do for her baby, is get the vaccine to prevent the sequela of preterm birth. It's an ultimately market that costs billions of dollars in our country is preterm birth. And ultimately, these babies will stay in the NICU probably till their due date. So if you have a 28-week baby, you think there's probably about a 10 to 12-week period in time where they're going to send in the special care nursery, and then all kinds of things can happen there that are accidental with sickness, viruses, complications, and this is the global problem of COVID essentially.
So it's the difference between leaving the hospital after a few days after you deliver with a nice, normal, healthy baby versus your baby being in the ICU or in the special care nursery for 8, 10, 12 weeks and not having at all that normal start that we would like to see.
Exactly. In a perfect world, we all want to go say, honey, it's time, go and have a baby and take your baby home in 2 days and start your life. But that's not happening in these cases.
Thank you, Mike. One question, Nora, that I do get from patients a fair bit is about the relationship between the flu vaccine. The flu shot is now, hitting local pharmacies and provider offices just this past week. And how does that impact getting the COVID vaccine?
So there is no contraindication. So you don't have to wait to get your flu shot after the COVID shot and vice versa. So we are approaching flu season. So it is really important for everybody, especially pregnant moms, to get their flu shot as well as the COVID vaccine.
Thank you. We do have a question from Candace Price.
Yes, so I want to ask about ivermectin. How common is its use currently in hospitals? Do we know? And we've seen doctors across the country sort of say we're refusing to use it. But I know in our region, we had at least one judge give approval for doctors to use it. So I just want to understand what we understand about that drug and its effectiveness against COVID at this point, and how common its use is in our region.
So I will start, and then I'll turn things to Dr. Colburn. Ivermectin is used in our region, but it's used to treat lice and it's used to treat scabies. It's mainly used by our dermatologists and to some degree by infectious disease practitioners and occupational medicine doctors. It's not traditionally used outside of that. And certainly our guidelines here at the OSU Wexner Medical Center, because they're based on evidence and published evidence, are not recommending the use of ivermectin for hospitalized patients. Dr. Colburn, I can talk a little bit more about the judge in Cincinnati, but do you want to comment just in general about, from the infectious disease perspective, the role of ivermectin?
Yes, so I'm an infectious disease specialist. I have used ivermectin a handful of times on patients with parasites or scabies, and that is the indication for it. There have been excellent studies done. There is no benefit in COVID-19, and it is not the standard of care, and it should not be assumed to be such for COVID treatment.
And I think that's been made clear by CDC, FDA, the Ohio Board of Pharmacy, a variety of folks guideline-wise in terms of our national organizations that have really come out saying this is a risky medication if used inappropriately, and can cause side effects even in used in normal doses. That is really not to be trifled with. I'm not completely familiar with the case in Cincinnati. I've read news reports about it. From what I understand, this is a patient or a family of a patient who insisted that their family member be treated with that. The providers, physicians at that hospital felt relatively similarly, from what I understand, as we do. It's not in their guidelines. It's not recommended for treatment. And members of the patient's family went to a local judge and actually got a court order to require a provider to treat the patient with ivermectin. So that's obviously an incredibly rare occurrence. Certainly for a court to order a physician to treat a patient for something that has really no evidence and there's no recognized benefit was striking and pretty surprising. So that's Candace, does that answer your question?
Yes, it does. I think I was trying to get an idea if we have a number of doctors using ivermectin currently to treat COVID patients, or do we have an understanding of how common it is for it to be used to treat COVID patients right now in our state?
So I don't have statewide data or zone-wide data. All I have is the data from here at Ohio State. And we did pull our uses of ivermectin and took a look. And they're really, like I said, used by our dermatologists, by our infectious disease doctors, and our occupational medicine physicians. When we have a patient that comes into the hospital with scabies and we have staff that are exposed to that individual, they'll be prophylactically treated for scabies is really the main uses of it. It's not being used here at the OSU Wexner Medical Center, and I don't think it's being used by any physicians who are actually following the evidence and the guidelines for treatment of COVID-19.
Got it. Thank you.
Thank you. So we've reached our time for today. Really want to thank all the members of the media. We'll be returning to have another one of these in the coming weeks, and we really appreciate your time and effort in getting the best information out to our communities. And once again, thank you for your partnership. And we look forward to being with you again in the near future. And thank you to Dr. Colburn and Dr. Kakovic for their time and being here with us today and their expertise. Thank you very much. Take care.